Hello, everyone, and welcome to OutTalk. It's lovely to have you all joining us today. I'm really excited about our conversation today and our panelists who are joining us. Just a few things you saw in the introduction, some of the things that OutCare does. It's an amazing organization. I've been involved in them for quite a few years now. Everything from training for medical providers and organizations to some really, really beautiful and wonderful support groups that are being created all across the nation. OutCare would love to have you join our community building and support groups. There are new ones happening every month, creating safe and exclusive spaces for LGBTQIA+ people and their allies to really come together. And these are free services that are provided. Next week, we're going to have an Embrace Your Spectrum for transgender, diverse, and non-binary communities. And there's also Shades of Pride, a space to uplift Black voices, all coming out. And you can find them on outcarehealth.org. And also, I'll let you know again at the end of this, but be aware that next month on Thursday, August 18th, our next OutTalk is going to be about kink-affirming conversations and how important this is for all of us who are providers in the community. So with that said, I'm very honored and excited to introduce our panel to you. And actually, in all honesty, I'm going to have them introduce themselves, tell a little bit about who they are, what they're currently doing, and they're getting a surprise bonus question, which they're hearing for the first time right now. A favorite food from your childhood that brings up wonderful memories for you. So with that said, I think Juan Carlos, why don't we start with you and see where this takes us?
All right. Hi, everyone. My name is Juan Carlos Venez, he, him pronouns. I'm a family physician in Indianapolis, Indiana. I work at Damien Center, which is Indiana's largest and oldest HIV/AIDS service organization. And there I do primary care, HIV prevention, LGBTQ plus primary care, and that includes gender affirming hormone therapy when patients need that. And I also am an assistant professor of clinical family medicine at IU School of Medicine. Was formerly on the board of OutCare Health, and I'm proud to be, here part of this IU community where OutCare Health was kind of born. I'm really excited to see all the cool work that's been done in the years that have passed. And I mean, I grew up in a mixed cultural environment, so I'm half Mexican and half American, I guess you would say, half white. And I think of mashed potatoes and pastel tres leches. So I think about, those are my two favorite things. My grandma's mashed potatoes are the best.
I love it. I love it. I'm guessing the two of those don't necessarily go together, though.
No, but they're always, welcome to have at any meal.
Beautiful. Thank you so much for sharing. Priscilla?
Thank you, John. My name is Priscilla Gutierrez. My pronouns are she, her. I am a certified trauma recovery coach. I'm also the founder of Cycle Breakers Club. I also work for the Reframe app. If you've heard of it, it is to support people on their alcohol reduction journey, as well as a scholarship program, DC Future Scholarship Program based in DC for first generation Latino students. And as far as my favorite food, I'm kind of inclined to say Taco Bell. I know it's a little cringe, but the reason I choose that is because my brother and we would love to compete with each other. So when we got the tostadas, we'd be like, all right, I'm going to put 10 fire sauces. Okay, then I'm going to put 11 fire sauces. And we would just compete. So I'm going to say Taco Bell.
I love it. And it's so fun to see how food memories bring up so much essence for so many of us. That's so cool. So do you and your brother still compete?
No, I don't even eat meat anymore. So I definitely changed my eating habits, but we still compete in different ways for random things.
Cool. And Carlos?
Hi, thanks for having me, John. My name is Carlos Salama. I'm an infectious disease doctor in Elmhurst Hospital in Queens. We are one of the busiest public hospitals in New York City, in the big network there. And I work in the infectious disease HIV clinic and on inpatient consults. I was the director of the HIV clinic for over a decade. And more recently, I am now the director of global health, and our main thrust has been to connect undocumented patients with more social care in the community through community-based organizations, primarily Latino ones. Food-wise, my family's from Argentina, but my grandparents are Syrian. And I remember eating my grandmother's kibbeh and lahmacun, which I don't know if any of you have heard of that, but my mother still makes that food. And when I go over, I go down to her humongous freezer and I try to make sure that she makes some of that today. It's really delicious stuff.
And you see the smile that just came up on your face? Yeah, I love this moment of sharing. So my name is John Sobek, and I'm a therapist here in Pasadena, California. I specialize in working with LGBTQIA+ adolescents and their families during the coming out process. And I'm the author of Out, A Parent's Guide to Supporting Your LGBTQIA+ Kid Through Coming Out and Beyond. And if I think back to a food memory, mine is actually going to be, this is so random, fried bologna. Now, the only reason this comes up, it's not as something that's my favorite thing, but it was the one thing my dad would make us for dinner if my mom wasn't home, to make sure we actually ate a good dinner. And he'd get out the cast irons pan and then just fry up bologna and put it on some bread, and we'd all be happy as could be. And that's one of those really random memories that comes up for me when I think about childhood food moments. So there is one thing that I had talked about with our panelists before we spoke, and that is, for me, as probably the whitest person on this panel today. Hello, magical. I just turned red and then turned white again. Is that I want to approach this with a lot of cultural humbleness and curiosity. And so I do want to definitely lean on the expertise and lived experience of our panelists to represent this conversation. And one of the places that I think could be really important to start with for our audience, there's this movement in the community about, and it was even in the description of this, about Latinx. And I also have people in the community who absolutely refuse to use it. And I'd be curious to hear from the three of you what your experience is with it, what it means to you, if it has any meaning at all, and how we can help our clinicians who are listening with us today to maybe work through this, this topic. And Priscilla, you had a very strong reaction, so I'm going to just toss it right over to you.
Thank you, John. So I reacted that way because literally, I think yesterday, I wrote a comment on someone's post about her experiences as a Latina. And in my response, I used Latinx. I said something in Latinx communities. And someone commented, Latinx is not a thing. That's really offensive. And I was like, and that was not the first or last time I know I'm going to confront or experience that type of reaction. My personal opinion is I'm for it. You know, in Spanish, everything is gendered, la or el. And as we know, there's a spectrum of gender identity. And so to me, it's just being inclusive. And some people will say, well, you can't even pronounce that in Spanish. So obviously it's not for Latinos, you know, someone else made it up. And you can say Latin. So I've heard Latin, Latinx. So yeah, I'm all for it.
Mm-hmm.
I mean, I think that people should feel comfortable using whatever. I don't think when people say Latino, Latina, Latinx, that, you know, a lot of people are really thinking so much about discriminating about anybody or leaving people out. I try to use Latinx as much as possible because I want to be inclusive. I recognize I didn't do it just now when I spoke about it, but you know, I think we should all do whatever possible to make everyone feel included and happy in life, and avoid barriers and discomfort.
Mm-hmm.
Yeah, my reaction to the term is like, well, so I think that also I've heard inklings of like controversy or maybe people not feeling comfortable because a lot of the spaces in which this was adopted and used in the United States are spaces that are predominantly like white and majority spaces. And like in Spanish, there's been a movement, I don't know, in countries like in Argentina and South America that tend to have been more progressive in pushing like our thought around, say, gendered language in Spanish, about using like gender neutral endings to the gendered words in Spanish or gender neutral pronouns. And so I've heard it like Latin, Latine, And if you watch Drag Race Mexico right now, there's lots of inclusive, amigues, chiques, like you can go to a drag show in Mexico City and hear this language. And I think it just is really inclusive, and it makes me happy to see that movement happening in the Spanish language, especially when it's used amongst, people who communicate in Spanish. But I also, like my mom was a Spanish instructor, and she's very strict by, like, she's from Mexico and has her master's in the in Spanish language and Latin American studies, and she's very strict about this. So, but it's just interesting to see that. I think it just means different things to different people. And when it comes down to like taking care of patients or the clinical setting, it's just like I talk with people about gender identity or sexual orientation. I don't ever push labels on them. I just let them tell me how they identify.
Mm-hmm.
And I think that's kind of the key when it comes down to it.
Mm-hmm. And just looking at like working with patients and clients, what have you over time identified as maybe some of the barriers that the Latinx community has to either accessing care or accessing care that is appropriate and inclusive of their story and their LGBTQI plus identity? What are some of the things that you have seen that maybe some of those barriers have been historically?
In my opinion, undoubtedly it's language. We have a huge deficiency in providers who can speak the language, who feel comfortable communicating well in the language. And that's particularly in the behavioral health space, where there are just a huge deficiency in behavioral health Spanish-speaking individuals. And so, especially with behavioral health, patients want to speak in their language. Even if they speak English, they would prefer to speak in Spanish to discuss their feelings. And so I would put that first, apart from, gender identity and all that. Just being able to just communicate, I think is a big issue.
Mm-hmm.
Absolutely. To add to that, Carlos, I would say, because I work in the mental health space, and I would say the taboos that exist in our own culture. So for some of us, we grew up with the notion that if you seek therapy or go see a psychiatrist, you're loco, you're crazy, something's wrong with you. Or you're also being disloyal to the family, because for many of us, we're raised on familismo, collectivism. So disclosing trauma or disclosing things that happen within the household can often be perceived as you're going against the family. So that's what I've seen mostly.
Mm-hmm.
Yeah, I would just want to echo those sentiments. I think that comes with, so the medical providers or the clinicians, the mental health providers and people in the healthcare space, understanding that those cultural significances that Priscilla just shared, like those are definitely true. And I find this myself, like I'm raised in the United States, but my upbringing is such that I have a familiarity with the culture of my family on my mom's side, right? And I've had this experience of being a Spanish language speaking, physician, and having patients like gravitate towards me because they can communicate, or they sense that I can pick up on those things. And so, I mean, for me, it's exciting to be accessible to those patients, but I hear about all the stories where they weren't able to access that, or I don't have someone to send them to, like if they need therapy or something like that. And it, like, again, that's going back to what Carlos said, which is language. I feel like at the root of it, it's that understanding of that significance of identity in people's lives and the traditions and cultural values that are so important.
And Priscilla, you used the word, I believe, was collectivism. Could you expand a little bit more on that and maybe share how it might influence a person's willingness or desire to seek out medical care, and how that collectivism might influence those stories?
Sure. So collectivism is essentially the family unit supersedes the individual. So let's say if you come from a low income household, if I'm like, I'm going to prioritize my self-care, that might not be well received. It's like, no, let's see what the family needs, and let's make sure that we're doing what we can for all of us before you put yourself first, especially if you are Latina. I'll speak for myself. Many of us are taught to be self-sacrificing and things like that. And so, yeah, it's really ingrained for many of us.
And do you as a panel believe that that collectivism you're talking about also maybe influences the ownership of LGBTQ identity as well? I stumped the panel.
Yeah.
Carlos, it looked like you had some thoughts on that maybe.
The sexual identity and gender identity is really complicated. In my experience, that family cohesion that Priscilla's speaking about ends up being a really strong help for patients who are struggling with gender identity, even with HIV stigma, right? That once they discuss this with their family, I think that they find ears in the family that are really there to help them. I mean, especially moms. Moms, I take care of a lot of young gay men who are recently diagnosed with HIV, and they think they can't tell anyone, but nevertheless, their mother's always going to come with them to the next appointment if they can, if they're around, they're not in their own country. And so I think, although I understand what Priscilla's saying, that sometimes women feel like they have to give more to the family than to themselves, I think that there's also the flip side of those same women are helping others in the family and getting help themselves from that collectivism of the family unit that is just so important in the Latinx community and really helps them get through the difficult times. So I think it is a very positive part of the Latinx community.
Mm-hmm. Just go ahead, Juan.
Well, I was just going to echo that. I'm thinking of the examples of patients who are coming out in that process of coming out, and some of my younger patients, like adolescents and younger adults, who feel more empowered, I think, in today's United States, right, to start expressing who they are and say it openly. And I've seen a lot of times the mother figure kind of stepping in and doing what they have to do for the well-being of their kid. And in my own family story, this has played out in this way. So it's kind of personal for me that I've seen it play out positively. And what I've also seen is this difficulty, and it exists across cultures, but like that toxic masculinity, machismo stuff, and sometimes the tension that can build in a family when, things are going against the way that things are supposed to be, right? And it can lead to my patients having experienced a lot of shame and even hiding and repressing who they are, running away from their family because they don't know how to confront that. So it does come up quite a bit, and it plays out in those different ways that was mentioned.
Well, one of the things that has been a topic that's come in some of our other cultural conversations has been this stacking of multiple minority stress. And this idea that the coming out process alone is a challenge. When you add on cultural constraints and cultural expectations, that can make it even a more challenging experience. Any thoughts on the multiple minority stress stack?
Well, I think that's why it's so important to have providers and counselors and therapists that look like their patients. I think we need to really stress the importance of elevating and educating everybody in this country. We live in a segregated country where white people live in white towns and dark people live in dark towns. And those schools are basically funded by tax money, at least in New York, that is very local. And wealthy towns have great schools. They go to good schools. They get good degrees, and kids that are in minorities just don't. And I think that's a humongous problem in this country because it keeps Latinx and Black communities suppressed, unable to get the number of high degree individuals that are going to look like their patients and allow their patients to feel comfortable in the office, talk to their doctors or counselors or social workers or whatever. So I think we need to do so much more work in this country to fix that.
Mm-hmm.
Absolutely, Carlos. I couldn't agree more. And so, John, what was it? The minority model stack? That's
multiple minority stressors. Okay. So where you're stacking more than one minority identity on a person.
Like intersectionality?
Mm-hmm.
Okay, yes, absolutely. And I mean, I don't need to read a book. I've lived it. I am a model, and we all are in some degree. And so I really agree with representation. For me, that was a game changer when I started to see women of color that also had diagnosed mental illness, who had similar experiences as me. That made me feel seen and heard and able to share my own story. And so definitely we need more representation.
Mhm.
It plays out significantly, like in people's like definitely, I mean, we see that statistically, I think in some of the information that went out kind of showing why we're talking about this at all. Why are we talking about communities of color and minority stress and health disparities? Because I mean, that all is, it's all linked, right? And when you have somebody in front of you, you're more often seeing the psychological and like physical results of experiencing that stress. And if you never try to listen, like I came from a privileged background, right? And so I can't like know exactly everything that my patients are experiencing, but if the healthcare provider doesn't take a moment to like sit, actively listen and try to hear where somebody's coming from and imagine what that experience was like without just drawing assumptions about their patient before they even walk in the room, I don't think we can do something about that, this very thing. Like we're not going to be much help to the patient at all.
Yeah, and if I may add about privilege, I think many of us physicians and even lawyers, maybe, I don't know, come from a privileged background. And you need to be privileged to be able to go to medical school, right? I mean, it's expensive. It takes, a lot of hard work and focus that if you grow up in a privileged place, you can give to something, right? You have to worry about work. My parents in Argentina my mother didn't finish high school, and my father was the first in his family to finish high school. And then he went to medical school, luckily for him. So, and that's where the ancillary staff, like nurses and social workers and others in a therapeutic area are so important. In our clinic, our nurses are absolutely amazing. They come from the community. They all speak Spanish. And when a young, Latinx or Black gay man walks into our clinic, he feels loved. It's a family because everybody there, makes him or her, whoever it is, feel comfortable in that space. And there is no judgment. People speak their languages, whatever that, well, we try. I mean, Spanish and English for the most part. So I think whatever, we need to surround ourselves in a staffed area with people from all kinds of places that have experienced all kinds of things, and most importantly, that are bilingual if you serve a primarily Spanish-speaking community.
And I want to make sure that our audience that's with us live today knows that we would love to have you throw questions at us. You can put that in the Q&A section or in the chat section, and we'll be able to pull those up. I see, Emmanuel, you put in there, anyone know of a central hub or list of LGBTQ affirming providers by state and specialty? Guess what? OutCare Health happens to have that directory available to you. So it is an amazing resource, and it keeps growing daily. And the thing that's really important is there are providers all over the country providing all kinds of different levels of care. But I think this also brings up another thing that's pertinent to our conversation today, and that is that there are care deserts in communities. There are places where access to care is almost it's inaccessible. And I'm wondering what your thoughts on how that plays into this idea for providers wanting to create spaces.
Well, I'm in Indiana, and I don't know that that's, I mean, it would maybe be a surprise to many people from around the country that in my particular area wouldn't think of as being the most diverse or something like that, maybe in terms of representation. But actually there's large communities of Spanish-speaking people. There's a large immigrant community. And we do find this a lot, that there's a lot of people who have migrated or come to Indiana for a lot of different reasons. And depending on where they are in our state's geography, like they could be in a huge desert. In my own community, I have difficulty finding therapists for patients who are bilingual. And what I've had to do in my setting was kind of use like what's the word when you like use I've created a Facebook group of just people and had them invite their friends, and these are people in the healthcare space. A lot of them are on OutCare, but we just like when we're trying to find something that can help a particular patient situation, we help each other find that resource. But I mean, it's very real, despite I think this goes back to what Carlos was saying in representation, because despite us having an increasingly diverse state in Indiana, I don't know that our healthcare workforce really represents that diversity. I don't know if we're on track to representing that diversity in any time, in the near future either.
Yeah, I personally can't speak to healthcare deserts, though I read a lot about it, and there are places where there's truly no healthcare around for big areas, and many rural hospitals have closed all over the country because they've just gone bankrupt. But I can speak to the fact that our undocumented community living in New York sometimes feel like they're in a healthcare desert because they have no insurance and they can't get medical care in a lot of places, right? So, and a lot of cities are not coming up with these insurance plans that provide healthcare. Like California is the best. They now are giving Medicaid to everybody, I believe, in California, regardless of documentation. Correct me if I'm wrong, John. And in New York, we have NYC Care, which provides some limited but good healthcare to our populations. Now, the city hospitals take care of everybody, so they can come and get care. But if you need subspecialty care outside the hospital, it gets really, really challenging for them. And so it's kind of similar, but we're blessed in New York to have so much healthcare around. So
being in the mental health space, I would say one solution is like alternative models. So like I work for an app. I work for different communities that started online, and I see my clients virtually, and I use a sliding scale. So that's kind of been like my role of trying to fill the gap, because not everyone has insurance, not everyone has the money to pay out of pocket for therapists or things like that. And so I know that there's the solution has to be systemic, but we can have different solutions and together hopefully resolve this.
Mm-hmm. Well, I think that's one of the things too about when we're looking for solutions and maybe move into a solution-based conversation right now. Like, what can healthcare providers do to maybe engage and become more involved in the Latinx community and organizations to really start shaping these healthcare policies? How do you see providers who are listening with us today who really want to step up to the plate on this? How do you think they could approach that?
I think trainings are super important. Helping staff members just feel comfortable, culturally comfortable, understand where people are coming from. If you move to New York and you get plopped in Queens, you need to know your community, and plopping people in who just came from another country, maybe in Asia, and they don't really know our community. They don't understand that we are a very progressive city, a very progressive country that is open to all kinds of ideas. It's really important. I can't even tell you how many times patients have come to me upset because someone was just not being kind to one of our patients because they were, transgender or gay, and this doctor didn't understand that, came from a different place. And I think training those people before they even start is so critical. And then language, I get back to language all the time because Spanish, and I'm going to say something a little controversial, maybe not in this podcast, but Spanish is the American second language, and everybody in medical school needs to learn Spanish. That it shouldn't be an optional thing. Everywhere you go, Indiana, North Carolina, places you don't expect a large Latino community, full of Latinos, right? So this is so important that we really stress language in training for providers.
I agree, Carlos. I mean, even John, how you started the meeting, just being humble and saying, hey, I know I'm not part of this community, but I'm here as an ally and I'm here to be respectful. So we need trainings. We need trainings where people understand certain cultural cues and gender affirming language, LGBTQ affirming language, some type of implicit racial bias training. Because as we know, Latinos, we're not a monolith. We're every type of race, every type of shade, every type of everything. And so I agree, definitely education and an open mind.
I think if I'm thinking about what I can add to what's been said, which I think is critical and kind of where my mind was going initially, I was thinking, what can I do? I mean, I can certainly do more outreach, and I'm fortunate that I joined an organization that was already doing a lot of work to reach out to the local Latinx community in Indianapolis. We have a whole team that's really aiming towards helping, strategically reaching folks to talk about HIV and to help bring people into care or help prevent HIV. But I also have a lot of privilege, so I can use that when I'm in an opportunity, to speak with somebody who holds a position of power to really make, do my job to advocate for changes. Or, I work at the medical school, so I've always been an advocate there for, what we need to do at the school to enhance our students' learning so that they can really be prepared to meet the needs of an increasingly diverse community that they're going to be serving, our population. However, I'm not going to lie and say that I don't get expletive tired all the time of feeling like I'm the one that has to stand up and say this. I really wish that my allies across the board, who the cis straight people, would help, everybody of all backgrounds. And in my environment, it tends to be the people who, they're immigrants or they're people of color, they're queer, and they're the ones standing up saying this. So we really need everybody to do this work.
Mm-hmm. And Priscilla, I would love to invite the panel to expand on something that you said that I think is really, really important for our listeners to hear today, is understanding the cultural diversities under this Latinx umbrella. We're using Latinx today in our conversation. Here in California, often someone will see someone of a certain skin tone and they will say Mexican, but they may be Guatemalan, they may be Honduran. There are all these layers. And I think it's become almost a monolithic story. And I really like that you brought that up. So maybe the panel could expand a little bit and help our clinicians and providers listening to maybe really be able to suss that story open a little bit more.
Sure. So trying to figure out what age did I realize that I didn't have a race. I don't know what to put when they have white, Black, Asian. I'm I'm not any of those. I'm a little bit of everything. And so we are an ethnicity for most of us. So Carlos, your background is Syrian, Argentina, Juan Carlos, white and Mexican. I'm Ecuadorian, Nicaragüense. And even John, there's Latinos that look like you. And so we have such diversity. And if you put 5 Latinos in the room, you're going to have someone that's Black, someone that's Indigenous, and we don't all have the same experiences. So Juan Carlos, you talked on privilege. I'm very privileged. I'm a fair-skinned American citizen, etc. I don't have a voice for someone who is brown-skinned and undocumented. And so it's really important, even within our own community, to educate ourselves about anti-Blackism, our internalized issues that we have through centuries of colonization. So I think just overall, there's a lot of education that needs to be done inside our group communities and outside.
I remember going through American history and learning about Chicanos and cultural movements and groups in the United States, and Mexican Americans, right? And then I always thought, well, I'm Mexican American, right? But my story is not I can't go to Chicago and understand what it's like for the Mexican American community there, or or to Texas and understand what it's like for people there. I mean, this border was plopped right in the middle of a country, right, and separated people politically, because of a border, and that resulted in lots of interesting dynamics and history that has evolved. California is a different environment. And, I grew up in an environment kind of surrounded by cornfields and having a very Mexican like side of my family where my mom was literally the only person in her family. And so I was more connected, I felt like, with what it was like to be Mexican in Mexico, right? And I try to meet someone here. So it's like you can't assume what my experience of my culture is or what being a Latino means to me. And I have the same thing. I don't know what to check on those boxes. I just know that I have my experience, and I'd like that people see me as, you know, as an individual and appreciate what I bring to the table.
Yeah, from my point of view, whenever I meet a patient, I ask them where they're from. I try to learn from them about their background and what they've been through. And I want to hear them. I want to hear their story, and I want them to feel heard. And that's what I try to teach our fellows in infectious disease who rotate through our HIV clinic, and our residents and our medical students. I think people want to be heard. They want to tell their story, and they want to be respected for whatever they are and wherever they came from. And I think this is just about respect, no matter where you came from. You know, Queens is the melting pot of America. It's unbelievable. It's, you know, we have people from just everywhere, but every Latino community is heavily represented. You cannot assume anyone is Ecuadorian or Mexican, or Colombian, which are the three big communities here, because people come from everywhere here. And you know, I like to talk to them about soccer, which kind of is an icebreaker with a lot of people from Central South America, and just get to know them. You know, I feel like I have a personal relationship with all my patients, and I think that elevates things beyond race and gender and everything else.
Well, Carlos, you bring up something that's been very thematic in a lot of our conversations, range on a wide range of topics. And this idea that there's a new movement in the medical community to once again sit down and actually talk with patients and learn who they are before providing care. Because we have a huge period in the medical industry where it's just about coming in, taking symptoms and providing care, and not looking at a whole-bodied person and how that affects what they're going through both physically, mentally, and spiritually. And so I just really want to point that out, because we have been finding this theme in like the newer approaches at medical schools to create this whole person approach. And I think it's pretty amazing to see it unfolding. And thank you for bringing that to your program as well.
Yeah, I mean, I would just like to give a caveat there, and that is that I'm an HIV provider, and so it's easier for me to do that because I have time. I don't have 3,000, 4,000 patients to take care of. I just have a few hundred, and it makes things much easier for us to do it. And I think, you know, in order to be able to do this appropriately, we have to respect our primary care physicians more. We have to pay them better, and we have to give them more time to see patients. Because what we're doing is we're burying doctors right now and adding more and more and more for them to do, and they have no time to do anything else. And then of course I don't want to bring up the computer systems that are just, so I think this is a really important issue, but I'm privileged yet again in that as an infectious doctor, I only have to take care of a small number of patients, whereas others are less fortunate and have literally thousands of patients to take care of.
Mm-hmm. Yeah, and that also pushes us into the, you know, challenges with the insurance-based model, which says you have 10 minutes to be with this person, and then you have to move on to the next 10 minutes, and you do that for 3 hours in a row, and then you get a 20-minute lunch, and you start all over again in the afternoon. And so I think that's something to be aware of too. The other thing that has been thematic in some of this conversations too, though, has been community clinic care tends to be so overwhelmed and swamped that is another place where maybe clinicians of privilege can find ways to connect and bridge services in those places as well. Have you seen that happening in communities at all from your experiences, or programs that are lending that kind of uplift energy? Wow, none.
I guess I'm curious about maybe an example of what that looks like. I think I'm one of those primary care providers that's talked about, and I've experienced burnout. I know it exists across specialties and professions. It's not just unique to physicians. But like you said, it doesn't, I feel like we're at this point now where you're seeing it in medical education, because we have more and more literature that shows that the way that we're doing things isn't really working, right? And it doesn't really, it allows implicit bias to like run rampant. And then we are getting back to teaching med students how to talk to people, so that we can do something to address that bias that happens, where we don't really see you as an individual. We see you by the color of your skin. And then we use all of those things that we've ingrained in our brain unconsciously about what that means. And I think that we're learning and we're finding ways to teach it in practical nuggets that I've been able to implement. So I think it's made a difference for me. I wish that more and more of my colleagues had access to that education. As far as like what's happening in the community health center setting or ways where we're doing partnerships, I mean, I still think it falls a lot on the people who are dedicating themselves to care for those who have been left behind. And I still think that there's more we can do in our local communities, like tax dollars was mentioned. There's a lot we can do to think creatively about how to I love listening to these stories on NPR where they're looking at ways to like create housing and like sustainable options in certain communities around the United States. I think we need to look at like what are those things that we're doing where we're not like displacing people, where we're like building up communities and investing, because we know that that actually helps us all. It helps us all when we can support those least privileged among us. But I don't know what those specific examples might be. I'm curious because maybe they're going on and I would love to learn about them.
I think we all have developed our workarounds, right? To figure out how to get things for our patients. It's so hard. You know, like getting a dental appointment for somebody. We don't have a dental clinic in our hospital, right? So we have to so I've actually done research of where I could send people for the dentist, where they can actually get free dental care, because if you don't have insurance, you have to get it for free. And so I think we all have our workarounds. Even within our hospital walls, it's hard to get appointments in subspecialty clinics. So my workaround is that I've become very friendly with the clerical supervisors everywhere. And I call them up and I chat them up and like, hey, you know, can you help me with this? So, you know, we all do what we can to try. I do want to give a shout out to CBOs, community-based organizations, because I think us providers and clinics and hospitals, I think we forget that we haven't figured it all out yet. And these are people in the community that have a lot of resources for the same community that we're taking care of, because it's in our community. And they can help us a tremendous amount. I work with a group called Voces Latinas in Queens. They're an amazing group that just connects people to all kinds of services that I can't connect them to. So I think we should all try to be using CBOs more.
Mm-hmm.
My input, because I don't work in a medical setting, but I live in Florida. And if we look at the state of Florida and the state of Tennessee, and I think it's important to consider the greater community and how that affects CBOs and individuals that are Latino and LGBTQ. Because if I'm going outside and I see, you know, anti-trans propaganda or just really homophobic language from politicians or neighbors, like that affects me even wanting to seek or even explore that. So I would say we also need to highlight building some type of tolerance or reducing stigma, or at a minimum, increasing support among us.
Mm-hmm. Yeah, and one really like kind of practical nuts and bolts thing that was on here in the city of LA for a while is actually providing transportation vouchers as a means for people to be able to get to services that weren't local to them in their community. And once again, can you research in your area as a clinic or a clinician or a hospital setting? Are there ways for your city resources to be used as a means for people to get to their services themselves? It was really amazing. The results of providing these transportation vouchers was amazing, because it was like, oh, there's the bus system. It's like, well, that's great, but it may take 4 hours back and forth, even in LA with a lot of buses, to get to and from a service. And then where do you find childcare? Where do you take time off from work? That these vouchers really increased access and were an amazing asset to the communities that they served. So that's a nuts and bolts thing. And maybe that's something that the people listening today can look into their city and see, are there smaller, granular programs that might help people find the services they need?
Like for folks living with HIV, if you're not connected, if your patient's not connected with like or an ASO or an organization that provides case management, that provides client navigation, like that's, I feel so lucky because the organization they're able to provide things just like that. And because we're looking at broadening who we serve and serving more of the broader LGBT community, we've sought funding to be able to offer that. So yeah, I think that's a really good example that I like. I appreciate you bringing that up.
Mm-hmm. So I have a favorite question I like to bring into our closing up of this conversation. And it really does, looking at what we've conversed about today, looking about the work that you've been doing personally, looking at the work that you've done in your community over the years, what is your hope or vision for the future of care for the Latinx community, the Latinx LGBTQIA plus community? What would your vision of a beautiful future that was growth oriented look like?
I mean, I still dream for a single payer healthcare system.
Mm-hmm.
Yeah, that's powerful, Carlos. I would say, going back to representation, I would love to see more queer Latinos in mental health professional roles, political roles, just all across the board. I want to see more of us, hear more of our voices. I think that will be very impactful.
Echo both of those things. I'd like to see paths for folks who are undocumented to be able to have legal status that gives them the benefits that I think that you should be entitled to because of what they contribute to in our country. I'd like to see, my young trans Latina patient like be able to be a nurse if that's what she wants to be, or a doctor, like that would be, I think, when we finally arrive. And I'd love to see medical education in Spanish. I think that was bold and I didn't think it was controversial, Carlos. I think that's a great thing for us to aspire to.
Mm-hmm. Yeah. And I think it's also, for me, about being willing and able to reach out into communities, understand our own privileges in these conversations, approach with cultural humbleness and curiosity as a way for all of us to grow, to support communities. I am not a believer in that some big government organization is going to solve things. For me, it's always been about each individual meeting another individual, finding their common ground, and then deciding to make change together. So for me, that vision of a future is creating deeper levels of care, understanding, and communication amongst all communities. Because right now in the environment we're in, many of us on this call in various different ways have been turned into the other. And I think that's always a dangerous place for us to be. And oftentimes when people meet us others in person, they're like, well, you're not like I was told you were. And I think that's a really powerful way for all of us to connect. So hopefully I didn't step on anybody's toes with that comment. So with that said, I'm going to bring our conversation to today for a close. I want to thank our panelists. It's been absolutely amazing learning and meeting each of you. And thank you for sharing with such honesty and vulnerability in our conversation today. Carlos, when you decide to run for the mayor of Queens, I will vote for you, even though I'm in Los Angeles. Your love for Queens like permeates through everything you say. It's really beautiful to witness.
Come visit. It's a great community. Jackson Heights is an amazing community.
See, the mayor's already pushing communities. I love it. So with that said, thank you to all of us who joined us today. It's been beautiful having you with us as well. The recording will also be available in about a week on the outcarehealth.org website. So you can use these for future training and conversations amongst your staff if you'd like to share them with them. Please make sure and join us next month, August 18th, when we do our next OutTalk and look about kink-affirming conversations. Once again, thank you all so much for sharing so beautifully today. be well, be safe, and I hope to see you all again soon.
Thank you.
Thank you.